So my name is Dr. Jason Bernard, and I am a postdoc here at McMaster University, working at our HPCS and McMaster University. And we have some exciting presentations coming up. We have a slide up right now that talks about the Q&A session. So after the presentation, which will be 5 minutes, if you have a question, use the raise hand. Either myself or Dr. Randall Sonadera will call on you, unmute yourself, ask your question, and then go back to mute. And all of that is just to try to preserve some bandwidth so that everybody can enjoy all the presentations. Let's see. I think our first presentation is making sense of negative interpersonal interactions in the clinical learning environment. And the presenter will be Meredith Vanstone.
Okay, so everyone can see my slide, and I've my first time giving a virtual presentation, so I just made myself a little bit of a script as we work through some of the concepts on this slide. So this is a project about interpersonal interactions within the clinical and learning environment, and in particular, we were interested in how medical learners and medical educators decided what counted as mistreatment and abuse, and what was just sort of rude or suboptimal behavior. So we know from a global meta-analysis that up to 2/3 of medical learners are exposed to routine mistreatment and abuse over the course of their clinical education. This is a problem because the consequences of mistreatment are severe. There's evidence that it's associated with depression, suicidality, substance abuse, burnout, a lack of clinical confidence, and attrition from the profession. Definitions of mistreatment in research and policy literature, however, are very wide-ranging and diverse. They tend to focus on identifying and measuring discrete categories of behavior. But previous research from our group and from others indicates that these clear categorizations may not reflect the experiences of many learners who report a spectrum of gray area experiences that they're not quite sure how to interpret. This established definitional ambiguity can exacerbate the low levels of reporting of mistreatment and abuse. It can prevent help seeking, and it can obviate opportunities for professional development and lead to mismatched expectations between learners and teachers. In this research, we sought to determine the ways in which medical learners and educators understand less than collegial interactions with colleagues and supervisors in the clinical learning environment. We wanted to describe how they made sense of their experiences and which factors influenced their perception of an encounter. So we used the methodology of interpretive description, and we conducted interviews with 49 people. 31 of these were Canadian medical learners associated with McMaster University at some point in their medical learning trajectory, and 18 of these participants were medical educators also associated with McMaster at varying points in their careers. In each interview, we asked participants to share their personal experiences with mistreatment, abuse, and unprofessional behavior. In particular, we asked participants for stories of encounters that they judged to be clearly mistreatment, some stories of encounters that they weren't sure about, and some instances where they knew of disagreement as to whether an interaction constituted mistreatment or not. When they told us these stories, we sort of explored them further with prompts to elicit the factors that the individuals used to make their judgments about what counted as mistreatment and abuse. So in terms of results, I think that our data affirms the previous findings that learners and educators conceptualize negative interpersonal interactions on a spectrum. But there was little consistency in the ways that the individual participants defined and labeled behavior. So we had many stories where people would describe very similar encounters, but had very significantly diverse labels for that type of behavior. However, we did see some consistency in the factors that participants used to formulate their judgments about whether or not a situation was mistreatment or not, even when they came to different judgments. So the ways in which participants made sense of their experiences can be understood through a metaphor of a prism, which is the big graphic that you see on the left-hand side there. A prism refracts a spectrum of white light into various component parts. The quality and features of the light which exit the prism is dependent on the material, the angle, and the relationship between each element that composes the prism. We use this metaphor to describe the nature of the spectrum of behaviors which enter the prism and the ways in which participants use 3 different types of factors: interaction-specific factors, initiator factors, and recipient factors, to make sense of the behaviors that they encounter. So one thing that this metaphor does is that it recognizes that a way a person makes sense of any given interaction is highly dependent on factors relevant to both the interaction and to the person interpreting the interaction. So as one educator said, in the exact same situation, exact same words were said by the same preceptor in the exact same way, two learners could perceive it very differently. So these three types of factors form the sides of the prism, and they're being used by participants to make sense of the interactions they encounter. Interaction-specific factors are those related to the context, the content, and the target of the interaction. Initiator factors include the perceived intent of the initiator and the relationship the recipient has with the initiator. Recipient factors include identity, features, and experiences of the recipient, as well as the potential or anticipated impact of the interaction on the recipient. These three categories are not mutually exclusive. They often overlap and influence each other, both intensifying and in mitigating ways. While we identified some trends in how specific aspects of each factor tend to influence perceptions of severity, the trends are not absolute, and we have many examples of factors working against trend. So I'll give you one example of this. Overwhelmingly in our data, when somebody had a negative interpersonal interaction occur in the presence of other people, they were likely to judge the behavior as more severe. So one learner said that obviously the nastiest way to do it is in front of a huge audience of your peers and residents and other physicians. So this was sort of a trend. If there's more people there, it's more likely to be labeled as mistreatment. However, we also collected stories where negative interpersonal interaction occurred in an isolated or secluded place, which heightened the recipient's sense of vulnerability and magnified their perceptions of severity. So one educator told us a story from her time as a learner and said that the interaction would have felt less abusive if it was in a shared learning environment. We couldn't leave. It was awful. It was in this closed room at 9 o'clock at night in the top of the hospital. So just to conclude, our findings highlight the challenge of using standardized definitions of mistreatment and abuse for education policy or research. Individuals interpret their experiences in highly contextual ways, forming an assessment based on multiple factors relevant to the interaction, the initiator, and the recipient. Our analysis emphasizes the importance of organizational and professional culture in normalizing behavior and creating standards for interaction. Our research highlights the challenge of conceptualizing some kind of objective threshold for determining or defining mistreatment, which poses difficulties for institutional accreditation, which often relies on creating reports of students, what percentage have experienced this, for disciplinary and remediation action, and also for conducting research on this topic, or any kind of measurement of prevalence of mistreatment and abuse. So that's it, and happy to take your questions. And I'd also, of course, like to acknowledge my collaborators who are listed in very small font at the bottom of the slide. Alice Kavanaugh, Amanda Bell, Catherine Connolly, Margot Mountjoy, Anne Wong, Rob White, and Lawrence Gerson.
Yep. Oh, I muted myself on my headset. Couldn't hear what I was saying. So thank you, Meredith. That was very interesting. And at this point, is anybody seeing my participant window? Because I'm getting conflicting reports here that people are seeing my window. Okay. I'm assuming nobody is. All right, so if anybody has any questions, raise your hand and we will get to the Q&A. And keep in mind, it's a long list, so I kind of have to scroll up and down.
Okay, so Laura says, I wonder if you might tell us a bit about the range of contexts that were addressed and the kinds of concerns that were expressed about the contexts. Okay, that's a great question. So I think a little bit more detail about our participants is probably helpful. So these were, the learners were anywhere from current medical students. They all had to have some clinical experience. So these were sort of clerkship level medical students up to subspecialty fellows. And our educators, similarly diverse in terms of their specialty and their practice context. We spoke with people who worked in academic and also in community settings. And learners, of course, had diverse clinical experiences, including rural rotations, being in a big team in an academic teaching center. They talked sometimes about rotations where they were the only learner, rotations where there was a lot of other learners. And these contextual factors about who was there, what resources were available to them, what types of support they had themselves for sort of interpreting or debriefing about something confusing that happened. Those all help them understand their experience.
Okay, we have a question here from Sid Osami. Am I pronouncing that right? I think.
I don't see it. It might be a private message to you because I don't see anything. I see another.
There's a hand up from Syed.
Okay.
Syed Osami, yep. Go ahead.
I have a question. Thank you very much for your talk. I just wanted to know whether the initiator factor or the recipient factors were more predominant in negative interpretation of a interaction. Which were more predominant?
I think that it depends on the particular nature of the interaction. We had examples both of really severe types of mistreatment, but also less severe types of mistreatment where both the initiator or the recipient factor sort of took precedence. And then a lot of really rich and interesting data from the educator group about the factors that they thought from the recipient or their sort of thinking about learners and what affects a learner's interpretation of their experience, some of which bore out in our data and some of which didn't. So an example of this would be, we found that medical learners who'd had experience working outside of medicine or working in a different type of health professional capacity before they came to medical school often had a much higher threshold for what would count as mistreatment or abuse for them. So we had people who'd worked in corporate settings or people who'd worked as other healthcare professionals who would just let things that to me sounded very, very severe kind of roll off them as this happens, people are under stress, people are tired, you just have to roll with it and move on. The students who didn't have that kind of experience before they entered medicine were much more likely to judge those types of interactions as very severe.
Thank you.
Thank you.
Okay, thanks again, Meredith. We're going to move on to our next presentation. But that was very interesting. And if anyone has any further questions, of course, you're more than welcome to directly message Meredith, and I'm sure she'd be more than happy to answer your questions. The next presentation we have, let me see if I can press the right keyboard this time. Hey, look at that, is Anything But Cookbook Medicine, Exploring the Influence of Supervisor Practice Variability on Resident Learning. Resident learning is something we're looking at right now, Randall and I, so this should be very interesting. And the presenter is Suraj Mithwani. So if you could.
Yeah, I think things are set up. So thank you for inviting me to give this talk. I'm Suraj Mithwani. I'm a hematologist and a clinical scholar in the Department of Medicine at McMaster University. And we did this project in conjunction with local supervisors, Michelle Zeller at McMaster and Jeroen van Marienboer at Maastricht University. And I'd like to also thank Dr. Pascal van Gerven, who is a mentor and a secondary reviewer for this project as well. So clinical practice variability is a phenomenon whereby two or more expert clinicians who have similar knowledge and who have similar experience see the same patient, but who come to different management decisions about the optimal diagnostic or treatment plan. One might argue that clinical practice variability reduces the standardization of medical care, and in some contexts, this can be problematic. But we know from prior research that clinical experts often deviate from the best available medical evidence or clinical practice guideline recommendations in order to account for relevant contextual and patient-specific factors that are relevant to decision making. And the late David Sackett, or the father of evidence-based medicine, I'm sure would agree that a cookbook approach to individual patient care is not truly consistent with the practice of evidence-based medicine, which integrates best available evidence with clinician judgment and patient values to make the optimal decision. The phenomenon of inter-supervisor practice variability is relatively underexplored in medical education. And so we sought to answer these two research questions. Number one, how do thrombosis medicine residents interpret and experience practice variability? And number two, how does this inter-supervisor practice variability influence learning in a thrombosis medicine clinical rotation? So we answered our research questions by conducting a qualitative study whereby we did semi-structured interviews with 13 senior residents from PGY 3 to 6 in internal medicine, hematology, and thrombosis medicine. And we collected and analyzed data iteratively and concurrently in a manner that was broadly consistent with constructivist grounded theory methodology. We coded transcripts in duplicate, initially using a literal coding technique and then an axial coding technique where we collapsed codes into different categories and eliminated redundant ones. We recruited participants purposively and until we had an adequate understanding of the phenomenon under study with no major gaps in understanding. We maintained an audit trail and reflexivity journal, and we used an underlying theory called variation theory to help frame our understanding of the second research question. So variation theory asserts that learning occurs by experiencing variation in a phenomenon's critical aspects. So let's take one example here, which is imagine if you're trying to teach a child what the color green is, and they have no prior knowledge about colors. So you might do this in the following sequence. First, you might present the child with 3 different objects that vary in color, but that are similar, but in all other respects. And so that would help the child unlock the concept of color and the value of green, or the critical value of green within the critical aspect of color. Afterwards, you want to teach the child to generalize green across different instances. And another way to say that is you want to teach the child that green is green, no matter what the form of the object. And that's the generalization phase. In the third and most complex phase, you vary multiple critical aspects simultaneously. And so in this phase, you try to teach the child the part-whole structure relationship of the phenomenon. And in this example, you might vary the shape of the object and the color of the object simultaneously. So this is a theoretical model by which people learn from variation. So moving on to the results and some of the discussion, we found that clinical practice variability, as we expected, was commonplace in thrombosis medicine and encompassed virtually every aspect of the specialty, despite it being grounded in a rich evidence base. We found that learners attributed practice variability to different supervisor, evidence, learner, and patient factors, and that practice variability was also bounded by environmental or institutional norms. In order to learn from practice variability, you had to have the right combination of learner characteristics, so motivation, knowledge, and experience, and you had to have a supervisor that brought practice variability to light and made it explicit by modeling, thinking aloud, coaching, and providing cognitive feedback. When learners learned from practice variability, they did so in a pattern of contrast, generalization, and fusion. Some of the quotes are illustrated above, but we can maybe get into that a little bit more during the discussion. So in conclusion, we found that practice variability is very common in thrombosis medicine, that it was in a way a higher order form of variation beyond just the case mix that residents see during clinical rotation. And finally, we saw that we have some theoretical basis to, or a theoretical argument to explain why practice variability might be a useful form of variation in the clinical environment, at least for some learner-supervisor pairs.
Okay, thank you very much for that presentation. Very interesting as well.
Thank you.
And rather than having me scroll up and down looking for raised hands, it's probably going to be easier if you have a question to simply type it into chat, and we can go from there. Just a quick note, I've been told that the previous presenter was Dr. Vanstone, and of course I didn't mean any insult to anybody. I don't have a list of titles, so if you're a doctor and I didn't call you a doctor, I definitely didn't mean any insult by that, and I apologize. So now we'll take questions. Go ahead.
So
and we have one there from Tavis.
Perfect. I think Tavis has done a lot of actually prior work on this topic, so that's great. so the question is, was there much discussion in the data about how how learners navigate supervisors' pattern of variability led to different levels of access to autonomy in patient care? So I'm not sure if I'm understanding the question exactly the way you intended, but I think that autonomy is a concept that came up actually recurrently in the interviews. And I think one of the things that came up was the motivation for why learners actually wanted to learn from practice variability often depended on whether or not they were learning for the sake of, say, matching the supervisor's preferences or predicting the supervisor's preferences, say if they're a very assessment-focused learner, versus those learners closer to the end of training who actually had a motivation. Their motivation was different because they were very close to entering independent practice. And so the level of autonomy of the learners obviously changed over the course of their training. And the ones that were most autonomous and were closest to independent practice, we felt, or at least they had a self-perception that they benefited most from seeing this variability. I guess I see other questions one from Tala. Do you think residents might have felt differently if you included more junior learners? So absolutely. So we didn't include junior learners. It's a limitation of the study because thrombosis medicine is a specialty that attracts mostly senior learners. So we didn't really have access to PGY1, PGY2 learners or enough of them for this study context. But that's a very interesting question. We tried to probe that a bit by asking learners about their prior experiences as a junior learner, because obviously they've gone through the whole spectrum of training. And actually universally, they felt that that practice variability, if combined with all the other forms of variation in the clinical environment, to a junior learner, that would be very, very confusing and potentially overwhelm the working memory during like a clinical encounter. But that as one becomes more senior and they have more well-developed cognitive schemes, then practice variability is actually more helpful to tease out nuances. I think that a question could have been answered more directly by including junior learners into the study, of course.
So next is the question from Lara.
Yes. Okay, great. So thank you, Lara Varpio, for your question. So in terms of next steps, good question. So I think that we have a theoretical understanding of variation in the workplace, but we don't have a complete understanding of the different factors that lead to like the different supervisor, learner, environmental factors that can actually facilitate learning from variation in the workplace. And also, it can be very difficult to titrate the level of variation to the level of the learner. And we don't have a good understanding, I think, of how to do that yet, either from a theoretical or a practical point of view. And finally, one might imagine that you might create an evidence-based interventions in order to convert theory, transition theory to practice. And that might be in the form of design-based research interventions and using process worksheets, case-based discussion, reflection, and coaching to actually translate supervisor practice variability into useful learning opportunities.
Great, thank you. I think in the interest of time, we probably need to move on to our next presentation now. There are a couple more questions and maybe you'd like to follow up with them separately.
Oh, absolutely. Thank you very much.
Next up, we have Applied Theatre with an undergraduate medical education and systematic review being presented by Bronte. Bronte, over to you.
Hello, can everyone see and hear me okay? Awesome, thank you. Okay. So hello everyone, my name is Bronte Johnston and I'm going to talk about applied theater and how it can benefit undergraduate medical education. For a bit of context, applied theater is used by those who do not consider themselves actors to implement change. This can include role-playing, observing performances, theater games, and is often employed in pedagogy. Medicine is an extremely highly demanding field. Medical students experience extreme psychological and physical stress on top of learning a vast amount of information within a 3 to 4 year degree program. In Canada, the 7-factor CanMEDS framework describes skills a physician needs and are an active part to guiding undergraduate medical education. There is always a demand to improve current undergraduate medical curricula. Therefore, we conducted a systematic review of the publications incorporating applied theater and undergraduate medical education within Canada and the United States to understand the effectiveness of this method and how it can be used to teach these required 7 factors of a physician. A literature search was done through select databases where 41 publications were found. Our search criteria was reapplied to have 16 publications that were subjected to an abstract review, where a total of 12 were included. I want to share 3 major themes of education, communication, and personal development, highlighting how applied theater can aid undergraduate medical education. Often, undergraduate medical students are overwhelmed with the amount of material they are responsible to know to become a medical expert. Applied theater highlights the importance of creative freedom, which fosters an accepting environment for students to become scholars. This teaches students the idea of how there's not necessarily one correct way to approach medical issues they will face as a physician. Overarching medical curriculums across Canada and the USA highlight the importance of altruism, something that is challenging to achieve in traditional course material. Altruistic behavior is exhibited often in simulations and reflections, which are embedded in applied theater techniques. Undergraduate medical students reported that it is so hard to imagine without experience, and we believe applied theater can help fill that gap. Learners were also highly receptive to incorporating applied theater and were able to experience different patient stories through the safety of a storyline, and to provide experiential education through simulations like role-playing new concepts they have learned in class. Verbal and nonverbal communication is required to becoming an effective health provider. Applied theater can be designed to focus on students' understanding of body language, eye contact, awareness, collaboration, and how they can advocate for medicine and their patients. This is fundamental, as well with respects to how learners can explore to become a leader in medicine. Our results illustrated more of an emphasis on verbal communication in relation to nonverbal. This can be improved by integrating a more defined balance within future curricula in a variety of ways. Finally, personal development refers to a student's ability for self-awareness and to improve their potential, which encompasses both the professional and personal self. The topics of personal development range from compassion, empathy, which was the most highlighted, perspective, realism, and well-being. Role-playing is an educational experience that enables students to further understand their role as a medical professional and also taking the opposite perspective by embodying the patient or a colleague. This creates a contrast that further elucidates the dynamic to the patient-physician relationship, compassion, empathy, recognizing emotions, and personal reflection in overcoming difficult situations. These are all essential skills for physicians. Altogether, applied theater has the potential to effectively teach the required material in comparison to traditional methods, and therefore should be further integrated in medical education. Applied drama has the opportunity to promote personal growth, connections, experiential learning, while having the flexibility to tailor around the 7 characteristics incorporated in the CanMEDS framework. As Hartley always says, theater skills are life skills. Thank you.
All right, thank you, Bronte. Again, if you have any questions, just type them into chat and either I'll read them or she will.
I just want to comment from Laura. Thank you so much for that podcast. I'm an avid listener to Key Lime, and I will definitely look into that after. Thank you.
And it looks like we have our first question from Anita.
Yes,
I'm wondering
hi.
how to approach. Well, you can see it in the chat. I don't need to read it.
Okay, no worries. So hi, Anita. Thank you so much for your question. Yeah, that was something that we considered, but it's important to recognize that applied theater isn't necessarily the traditional methods of standing in front of a stage and performing a monologue, for example. It can be boiled down into more relaxed activities with sitting with your cohort and discussing or coming up with and taking on a patient perspective. So it's not it is encompassing to people who are shy and maybe aren't comfortable with speaking in front of a crowd. It just depends on what activities are being done. To answer your question, Dr. Grierson, so he's wondering how applied theater provides any opportunities for assessing competence in reflection. If so, how? Yeah, there was. So in one of the papers we found, one of the comments that the authors included were that students really felt that it was beneficial that they could go back in their role playing and kind of reevaluate, oh, I should have done this in this scenario, or I could have done that, or what they had done well. These debriefs were done either personally or in a small group directly after their role-playing exercise. Just for the sake of time, I'm just going to move on to the next question from Angela. Do results tend to differ if it is peer-to-peer versus patient-to-actor? I wonder if learners can be more immersed when it is a stranger versus a colleague. Yeah, that's a really great question. And I wonder that myself. There was quite a diversity in the papers that we found between peer-to-peer versus patient actors like SPs. Didn't comment necessarily on the difference between peer-to-peer versus, say, for example, a simulated patient. But I feel that that is definitely something that would be interesting to explore. I hypothesize that the dynamic would be different from coming into the situation. You're familiar with your peer, you may feel more comfortable with them, you may not. And I think that could affect their performance. And also some people associate, say, simulated patients with a high intensity exam. So that may influence their performance as well.
Great, thanks, Bronte. In the interest of time, I think I'll move us along. There are a couple of other questions there that you might want to think about and get back to. I will just stress Lara's comment that this is a really great study and it would be a really fantastic addition to the literature. So I hope you're going to publish it soon.
Yes, we're working on that. Thank you, everyone.
Thanks, Bronte. And moving us along, the next presentation is on the impact of the College of Family Physicians Canada Certificates of Added Competence Program on the delivery of comprehensive care in Canada. And this is going to be presented by Dr. Grierson.
Hi there. I'm assuming that I'm audible. If I'm not, I'll just expect a whole bunch of chat notes to pop up in the window. Thanks for coming to NERD 2020 and to listening to this talk on the impact of the Certificates of Added Competence Program on the delivery of comprehensive care in Canada. Just start off by acknowledging that this is work that was conducted in the Department of Family Medicine with a number of colleagues in that department, Alana Alice, Alison Baker, Alexandra Farag, Jessie Guscott, Michelle Howard, Margot Mountjoy, Henry Sue, Catherine Tong, and Meredith Vanstone. But this report examines the impact of the CFPC's Certificates of Added Competence Program. In 2015, the college initiated CACs, this is the certificates, in 4 new domains of care, care of the elderly, family practice anesthesia, palliative care, and sport and exercise medicine. The goal of our research was to provide an improved understanding of the impact of the CACs and to give advice to the college about whether and how to implement additional certificates in service of increasing coordinated, community adaptive, comprehensive care. The goal was achieved through the pursuit of a set of objectives. We aim to inform the development of the fundamental profile for CAC holders, to develop an understanding of the impacts that the program has on the provision of comprehensive care in Canada, to develop an understanding of the factors that influence the success of the program in enhancing the provision of comprehensive care, to understand the impact of the program on the experience of the members, to develop an understanding of the program on trainees, and to articulate potential benefits and risks of the CAC program moving forward, with specific consideration for the introduction of new certificates. So a big study and probably could spend more than the allotted time on it. So I'll do my very best to overview it quickly. It was a multi-case study approach. 6 cases were identified to represent a variety of salient features relevant to the impact of CACs. The cases were groups of family physicians who worked in a coordinated manner. They represented a range of urban, suburban, rural, and remote contexts. They were located in regions with high and low concentrations of CAC holders. They served Anglophone, Francophone, and Indigenous populations. They were located across Canada and represented different remuneration arrangements and practice structures. At the end of the case study, we conducted a pan-Canadian survey of all practicing family physicians to confirm and refine our qualitative conclusions. The results show, not surprisingly, that there is considerable variation in the way that the certificates are understood and operationalized by individuals. And it's related to the specific domain of care, community, the relationships between practitioners, motivations of the practitioner, and needs of the patient population. Accordingly, our description of the CAC holder is built upon a broad perspective, and that it was tolerant of regular challenges to seemingly sound generalizations. As a start, we draw attention to the idea that the CAC holder is fundamentally one type of enhanced skill family physician, a family physician who acts at or beyond the current edges of the scope of family practice, and often at the points of exchange between family medicine and specialist care. In making this assertion, we describe all enhanced skill family physicians as care providers who have both specific expertise in complex areas of care and an important grounding in family medicine that informs the way they practice, the role in the community, and the relationships with patients and other healthcare providers. We move on to present examples of CAC holders' activities that reinforce and undermine the principles of family medicine, being a care providers. And it's still a collection of interactive elements that influence the effectiveness of enhanced skill practices with respect to the delivery of comprehensive care in Canada. We outline 4 typical models of care that CAC holders adopt within a community. We list factors, external and internal, to each physician group that interact to influence the effectiveness of practice for that group of patients. As part of the results, we highlight that the CFPC endorsement of the CAC program is the main distinction between CAC holders and those enhanced skill family physicians with non-CAC credentials or without any credential. And this endorsement leads to the idea that the college will prioritize advocacy for health systems and hiring practices that favor CAC holders. And this is a perception that has differential influence on practicing physician and resident trainee motivations for pursuing the certification. In conclusion, we highlight that there are some practice arrangements that facilitate comprehensive care through CAC holders and some practice arrangements that discourage it. CAC holders tend to have a positive impact on comprehensive care when they work in collaborative models that align with the needs of the communities, and they support the local generalist family physicians. We see that CAC holders are particularly effective when they are part of planned care delivery at the practice and community levels. Importantly, many of the factors that influence the effectiveness of the CAC program are outside of the direct scope of the CFPC. However, through the program, the college confers credibility and thus impacts the professional identity of its members, including those who don't hold a certificate. In this way, we conclude that the program has a downstream impact on healthcare delivery practices, affecting the perceptions and motivations of individuals who are in the position to make changes that enhance community adaptive care within their region. There's a summary of potential benefits and risks here, and we speak to the possible implicit values associated with the CAC program, and a series of recommendations are offered for the college to consider. It's a long list, so if that's a question, then I can address it that way.
Okay, thanks very much for that presentation. Very interesting. With everything that's going on in this country with regards to long-term care of the elderly, I think it's particularly timely as well. So now we'll open it up to any questions. And again, we'll just put them in the chat and take them as they come. And if there are no immediate questions, rather than burning time, do you have any thoughts on how this applies to everything that's happening with long-term care in Canada right now?
Oh, geez. Well, I think the issues affecting long-term care are much deeper than the certificate program offered by the college. But I do think that if we have a stronger primary care workforce that is engaged with care of the elderly in a variety of contexts, including long-term care, that we stand to avoid a lot of the problems that we see when these human resources aren't available or the expertise is not available. We run the risk of diverting care in the wrong direction. I think is the main thing.
Interesting. Anybody have any questions on certificates or anything else? I mean, we have an expert here in family medicine. I'm sure he'd be more than happy to take questions, even not necessarily on certificates. And we got a couple minutes left before we go on to the next presentation.
I have all the time in the world, Jason, to share my thoughts and opinions with this group. So, voted question: Are CACs an interim measure for a 3-year program? I don't know. I think that the question, though, speaks to the idea that there's a number of perceptions out there about what the CAC will or will not do for trainees in promoting their ability to secure the type of work and the type of practice that they want. In going through the study, we recognize that across each domain of practice, that the development of the certificate was fairly organic within that domain. And that the college, part of the reason for the study was so that the college could come together on the development of sound policy around the certificate that will influence care. With that in mind, we sort of propose this metaphor of the message in a bottle, that the certificate has been sort of thrown into to the ocean, and people might get it and wash up on any shore, and we just kind of hope that they're going to do what we want them to do when they get there, and the notion that we need to come to consensus agreement on what these certificates are for and how they're going to be utilized in terms of hiring, billing, remuneration structures, that the college has some policy work to do there.
Okay, great. Well, you answered a loaded question. And everyone knows those are harder than normal questions, so good job. I think there doesn't seem to be any other questions, so we'll move on to the next presentation. Now, we had somebody who unfortunately wasn't able to make it, so this is the next presentation in terms of the original order, and it is, oh, this should be interesting. Observing others' suture, do novices benefit from observing errors? This sounds very surgery related, and that I don't normally like to watch. So go ahead, take it away. Oh, I didn't change the slide. Hold on 1 second. I got 2. There we go. Okay, take it away.
Hi, so my name is Beth Sedaris. Can everyone see me? Yes, okay, it's working. I'm presenting today about the work of my undergraduate thesis entitled Observing Others' Suture, Do Novices Benefit from Observing Errors? So to start off, it's pretty well known that trainees, surgical trainees specifically, spend a large portion of their time observing others perform skills. That's often how they acquire a lot of their complex motor skills. However, there's a lot of debate in the literature as to what type of performance is most beneficial for learning of these skills. So there's evidence to suggest that observing an expert, which would be like a staff surgeon, provides learners with a correct mental reference to guide their performance of a skill. On the other hand, observation of a novice may be helpful because learners are able to detect and correct errors in their own performance by viewing a novice, because when somebody is learning a skill for the first time, they are observing errors because they're watching themselves make mistakes, and they're kind of updating their mental reference to kind of correct and detect errors in their performance as they go along. There's also evidence to suggest maybe a combination method is helpful by observing an expert followed by a novice performance helps them both learn and correct errors, as well as be able to kind of use that correct mental reference. So it's kind of clear that there's a couple different approaches in the literature, and it's kind of unclear at this point which one is going to be the most beneficial for learning. One way we can kind of measure if someone's able to correct and detect errors in their own performance if they're able to do the same thing when they're observing an other's performance. So it is known that high accuracy when you're estimating an observed performance, so measuring the amount of error in a performance you're viewing, If you're very good at this, it indicates you're also able to kind of do the same thing and detect and correct errors in your own performance. So in this study, we wanted to explore if the observation of errors improves performance on a suturing task and whether it improves participants' ability to recognize errors in performance. We predicted that those who were better at estimating errors in an observed performance would also improve over time in their own performance. So in terms of our methodology, we had participants observe the performance of one of 4 groups. So there was those who observed an expert, those who observed an intermediate, those who observed a novice, and those that observed an authentic novice. So the first 3 groups observed a performance of someone who was performing a shortcut technique for suturing. So the task was a simple uninterrupted suture. And the shortcut technique would be that a senior surgeon would usually use, and that's kind of a faster method that you would learn later along in your training. Whereas the authentic novice demonstrated the correct technique for a novice, which would be the initial technique they are taught, where they actually cross their hands over, and it's kind of the traditional technique that they initially use to learn the task. So all participants first observed the expert video. So all 4 groups observed first the expert, and then they had their first attempt at the task. Following that, they kind of broke off into their groups, and they either observed one of 4 groups depending on which group they were assigned to. And after watching that second video, they were given the chance to estimate the performance that they viewed, so kind of evaluate the level of errors they saw in performance, followed by their second attempt at the task. And then that final sequence was repeated once more. They again observed their group assigned performance, estimated that performance they saw, and then had basically their third attempt to perform the task. So as you can see here on the right, these are our 2 figures showing our results. So I'm just going to pull your attention to figure 1. So figure 1 on the y-axis shows suturing performance. So a higher number indicates that they were better at performing the suturing task. A lower score is lower performance. So the 2-way ANOVA revealed a significant main effect of attempt on performance, meaning that participants did differently over time depending on which group they were in. So looking at figure 1, we found that those who viewed the expert, the intermediate, or the authentic novice, those groups performed better over time, as shown by a significant difference between their first and their third attempt, whereas those that observed the novice did not improve over time significantly. And then if you pull your attention to figure 2, that graph is showing estimation accuracy, whereas in this case, a higher number is actually poor estimation abilities and a lower number is better estimation abilities, because the more accurate you were, the smaller the number was. So although the expert and the intermediate groups did do well in terms of their estimation abilities, they actually did not improve over time. Those that observed the novice and as well as the authentic novice improved over time, as you can see by a significant difference between their estimate 1 and estimate 2, where they got more accurate over time. So these results suggest that perhaps observing an expert, an intermediate, or an authentic novice, where an expert would be someone like a staff surgeon, an intermediate would be someone like a senior resident or a fellow, and an authentic novice, someone like a peer, may be more beneficial for learning a complex motor task such as suturing, because these are actually people who would be an authentic performance to be viewing. So the expert and the intermediate normally would be performing a shortcut technique, whereas an authentic novice would be someone performing a correct technique. So this suggests that if you're viewing a performance, you should be viewing someone who's performing that task at their designated skill level. It was interesting, we did predict that we would see that those who were better at estimating errors, got better at estimating errors over time, would be the groups that improved over time. And we see this is not the case in terms of our study. So this kind of suggests that perhaps getting better at estimating errors over time does not automatically lead to an improvement in performance. Thank you.
Thanks very much. Very interesting. And, you know, to me, I love it. It's got numbers, so that always makes me quite happy, and not gross pictures of stuff. And you already have your first question, so go ahead.
Perfect. So Laura says, so your findings suggest that novices can learn from the errors of others. Do you have ideas about why that can happen? If we understand the why and complement those insights with your findings, maybe we should be showing learners errors from specific individuals to boost their learning. Do we need to debrief with learners about the error they saw? Yeah, that's a pretty interesting question. Well, kind of the evidence showing that, and the reason why we thought people would perform better when they are observing errors, is because when people are initially learning a skill just by observing their own performance, they actually are observing themselves perform errors, and they kind of use that to kind of update a cognitive representation they have of that task, and they keep learning from that until they kind of form a correct cognitive representation. And that's kind of a benefit you can get from observing your own performance, but that benefit can also hopefully be from observing another's performance, and you kind of lack that when you're watching someone who's performing that perfectly. In terms of debriefing the learners about the error they saw, we did tell all participants that the performances they were going to be observing did contain errors. So we did tell them, okay, you're going to be observing either an expert, you're going to be observing someone who does make errors. So perhaps there might be a difference if you do tell people versus if you don't tell people they're going to be watching errors, and how that influences performance. And that would be something interesting to look at as well. Yeah. And I think we have one other, Dr. Grierson said, how about the differential value of different types of errors, process versus outcomes? Do errors that have bigger consequences have bigger educational impact? That's a really good question. That'll be something interesting to look at. We did read a couple studies showing that those that have kind of bigger consequences or bigger level errors do kind of influence learning more, but it would be interesting to kind of look at different types of errors rather than just one type of error, and see kind of how that influences performance. That would be interesting. Sam Jordan says, so the challenges that may occur with self-evaluation, is it possible that observing the errors of others may be more positively impactful for learners? Potentially, yeah, because I'm sure there's a lot of bias when you're observing and evaluating yourself. It would be interesting to see if people are evaluating themselves versus others, how that kind of changes how they learn over time. Because people are usually able to judge themselves a little bit differently than others. That would be interesting to see. Steve Slade says, so are you saying you have to actually make errors, not just witness them, to maximize your learning and improvement? There's kind of evidence to say both. So witnessing errors does kind of influence learning. Usually people would be making errors regardless if they're a novice at the task. It would be very unlikely someone kind of just doesn't make errors as they're learning a task. And it would be interesting to compare between people who are learning just from their own errors versus just from observing errors, kind of how that influences learning. But there's evidence to suggest that kind of both provide the same benefit, either those looking at errors and observing their own errors.
Great, thanks, Beth. If you're interested in finding out more, the article that Lawrence just posted is a really good one that has lots of good background reading. So if you'd like to know more about the role of errors in learning, that would be a really good starting point. So thanks very much for the presentation. Since we were shy of one presentation, I think I can let you get away a few minutes early so you can enjoy a little bit of a break before the next session. So thank you very much to all of our presenters. If you have any questions that weren't answered, feel free to follow up with them, and I will see you all in the next session.